All right, docs, we're going to talk about the cervical spine. Probably next to low back pain, the next most common reason why people visit us is because they got neck pain. A lot of these are good candidates for decompression, degenerated discs and arm symptoms and stuff, so you got to do a really good exam on this area too to determine what the pain generator is. So I always start out my cervical exam like I do almost all my exams, and I look at the feet. That's the foundation. So I observe, which we've talked about in other videos, for the 5 red flags of pronation. We always get digital foot scans, and then we look at their posture of their neck, both from the side. The big thing you want to look for is, do they have anterior head carriage? Because anterior head carriage is associated with pronation in the foot. And so you might think, well, why would you look at feet if their problem is all the way up here? But it's related. And putting in orthotics in their shoes can many times help with anterior translation of the head, forward head carriage, and can be very helpful. So I'll look at posture, both from the side and of course from the back and from the front. And then you usually just go to your seated position where the majority of the neck tests will be next. All right, we have Noah here in the seated position. This is where you're going to do the bulk of your cervical examination. And so I always start out with range of motion. Again, I rarely measure it, but I do visually observe for any restriction and of course noting for pain. So 6 movements: look left as far as you can, look right as far as you can, back to neutral, tip this ear to this shoulder, this ear to this shoulder, look down as far as you can, and look up far as you can. Okay? Is there pain? Which movements are painful? Are there any restrictions? Notate that in your examination. If there's been a whiplash type injury, then you definitely want to do passive range of motion with a maneuver called O'Donoghue maneuver. And so turn to the right, Noah, to what you can, and then slightly overstress it. Of course, that will stretch when you get to the end range, and then you exceed it slightly. That stresses the ligament. So if there's ligamentous injury, passive motion is painful. If just active is, of course, then it's more muscular involvement. And then O'Donoghue maneuver is, you would have them try to turn to the right, Noah, and you resist them. And then turn to the left and resist. And you resist in all the cardinal motions. Bring forward, back, left, right, okay? And so that's looking for muscle strain, and that's what O'Donoghue maneuver does. The passive range of motion, looking for ligamentous involvement, resisted motions in all the different planes, looking for muscle strain. Good test for whiplash maneuvers. If there's radicular symptoms, then you got to do foraminal compression tests. So people don't do this test right because they don't do what I call stacking the facets. You have to get the neck, you don't want it forward, you want to really tuck their chin in, bring the head back, get those facets stacked on top of one another, and then begin your compression. So classical foraminal compression is just straight on, but then there's different variations of it. So Jackson is left lateral flexion with the compression. And then you have maximal cervical compression, which is rotation with slight extension, and of course both ways with that. And then you have Sperling's test, which is basically maximum cervical rotation with pressure, and then you also can strike the top of the head for eliciting any type of radicular. Many times you'll find localized pain with some of these tests, which is more indicative of facet involvement. And then wherever you find the position of compression that causes symptoms, then go right from that position into distraction test and see if that alleviates the pain. If it does, it's a strong indicator of nerve, especially if it was causing arm symptoms with the ear compression, and if it was localized, looking at facet involvement. But if distraction test relieves, then you know they're probably a good, potentially good decompression candidate. If the pain increases, then you got some type of underlying muscle spasm. You have to figure out why that is there. From there, you go into shoulder depression test, which is another good one to determine are there nerve root or involvement. So people get this test wrong. Is shoulder depression test, folks, not neck crank to the right test. So you bring the neck to a certain position, then you push the shoulder down, tensioning those nerve roots of that brachial plexus to see if that reproduces their arm symptoms. If they have arm symptoms, many times the position of the Cody sign, where you put their hand right on top of their head, if they say, Doc, boy, my arm symptoms feel better when I'm in that position, that's a positive Bacote sign, and it's a strong indicator of nerve root involvement or compression. So anybody that has arm symptoms, make sure you put them in Bacote's position. The other thing is, a lot of people will say, they'll come in sometimes and they're sitting in your waiting room chair like this when they have these conditions, because that's the only position that they can find relief in. And so they'll just naturally put themselves into that Bacote sign. Then you always want to screen for thoracic outlet syndrome, and there's several good tests for doing that. The ones I do are one Adson's test. So Adson's, you bring the arm a little back, you palpate that radial pulse, you have the patient turn their head towards you and up. And some authorities say you're looking for a diminishment of the radial pulse. I like to see, does this reproduce the arm symptoms they get when they get their episodes of it, because that would be a very strong indicator then of thoracic outlet, usually due to scalenus anticus syndrome. And then Halsted maneuver, you tell them turn the opposite way, slight extension of that head, again, looking for reproduction of the arm symptoms that they tell you that they have. So that tests the scalings. And then you have to do Wright's test, which is Wright's hyperabduction. Bend the elbow knob, arm all the way overhead. This is looking for thoracic outlet syndrome from the pectoralis minor. And so you're looking either for diminishment of pulse, or you're looking for a reproduction of their arm symptoms, which is the indicator I usually like to see. And then, of course, both sides with that. And then I always do costoclavicular maneuver, which is we bring the arm back, keep forward now. We bring the arm back, we have them tuck the chin. And you can sometimes do this bilaterally at the same time, feeling those pulses and looking for, does this reproduce their arm symptoms, which would be indicative that they potentially have a cervical rib. So those thoracic outlet maneuvers will determine, one, if they have thoracic outlet, but two, what's causing the compression, scaling, pectoralis minor, or potential cervical rib. A lot of your radicular patients are also going to potentially have an underlying carpal tunnel syndrome. So I always come around to the front with them, and I will do Tinel's test over the wrist, looking for a reproduction of their hand symptoms. And then we also put them into a couple different positions, Phelan's test. So put your hands together like you're praying, elbows out, hold them together and squeeze. And usually you gotta have them hold that 20, 30 seconds to see if that reproduces carpal tunnel type symptoms. You can also have them reverse it like this and do reverse Phelan's. And that can also be a good test looking at for potential carpal tunnel syndrome. Then I always go, if they have ridiculous symptoms, again, go onto the sensor or the reflex, motor, and sensory exam. So make sure you always get bicep reflex, brachial reflex, tricep reflex, and then do your motor exam. So hold in, no, don't let me push, pull out, don't let me push in, arms down, wrists up, there's C7 here, don't let me push down, all the way down, don't let me pull up. Actually, the last one was C6, this is C7, like this, Noah, fingers, don't let me pull like this. Don't let me pull your fingers out, C8, and fingers apart, Noah, don't let me push them together. With T1, you always want to reference the middle finger and then compare that to like the index or the pinky or even the thumb, okay? And then, of course, sensory exam. So the motor, we got C5, 6, 7, 8, and T1. Those are usually the ones I covered. You can also add in other ones, like here for the delts, hold up, and that's also a good C5 test. Then, of course, sensory exam. Typically, I do C6, 7, and 8, but you can include other ones too. So I always for sure do bilateral thumb, bilateral middle finger, so C6, C7, C8. You can come up to the biceps and do C5. You can come to the inner lower arms and do T1. So C5 through T1 sensory. Very important test to do, folks. And also, if you have any hint they have carpal tunnel, or a lot of these patients that have motor weakness from a nerve root, it's a good idea to test them for grip strength. So we usually do one to 3 dynamometer readings on each side and record the averages of those to see if they've lost any grip strength. And this is a good thing when you're treating people with motor weakness to see how your treatment is progressing. Are they getting some return of motor strength as you're going along? So a simple dynamometer can be a very important test to do. I want to make sure I'm not missing anything here. That, I think, covers most of the tests that you want to do from the seated position for the cervical spine patient. Final thing, of course, is just, do your chiropractic evaluation. Check in the patient's cervical spine for misalignments, subluxations, and make sure with your whiplash injuries, palpate those SCMs, palpate scalings, find those spots up in the suboccipitals, trapezius muscles, levators. Those are the big muscle groups. You guys all know this stuff, and that's chiropractic bread and butter, is palpation and looking for misalignments. Probably didn't need to mention that in this video, but it's the thoroughness of it, docs. It's doing all these tests because you're trying to pinpoint what is the pain generator, because if you do that, you got a much greater chance of identifying what's going to help this patient the most. Are they a decompression candidate? Are they a laser candidate? Do they just need some straight up good chiropractic work? And you got to do the test to know what you're dealing with. And the more thorough you are, the more your patient will appreciate it and the more impressed they'll be. I want to show you one other clinical gem, guys, when doing the cervical spine exam. A lot of docs don't know about this test. It's called the upper limb tension test, and it's one of the best tests that can really bring out if they have cervical radiculopathy. So shoulder depression can be helpful, some of your foraminal compressions, of course, Bacodi sign, but if none of those are really quite showing it, do upper limb tension tests when they're supine. What I like to do with this test is rest their elbow right on my knee, and then what I do is I just grab their shoulder right on top. We let their arm, just let your arm fall back, okay? And you get it to a point where you can feel tension about as far as they can go, not forcing it. And then what you do is you straighten their elbow till you get tension, and then you extend their wrist, and then look away now. That, folks, tensions the whole plexus of nerves coming through here. And if they have pressure on a nerve in their neck, this will usually bring it out. So upper limb tension test, a good one, docs. Finally, doc, there's just a few other things to wrap up your cervical exam. One, get a neck disability index on them to determine how their neck condition is affecting their daily living. It's a great idea to use that to track your results and track your stats, how you're doing with these patients. It's a really good thing. X-rays, of course, are very important for anybody that has any radicular symptoms, looking for that disc degeneration. If there's been a whiplash injury, make sure you get your flexion and extension views, along with your APOM, APLC, and LCN. And finally, don't forget MRI. If you have somebody that has definite nerve root issues, and if they're not responding maybe to the first 4 to 6 weeks of care, definitely, and or if they have progressive neurological symptoms. And sometimes in the upper extremity, you may need to get an EMG too, especially if they have maybe a double crush syndrome, or they maybe have neck involvement, but maybe they have nerve entrapment at their elbow or their wrist, or maybe both or all three. And some of those cases can get a little complex, so you may need to have an EMG done to see if there is more than one site of nerve compression. Some of these cases get a little complex. So if you feel you need the test, docs, order the tests. That's the bottom line. So that would wrap up a very thorough cervical spine examination.